So today, we have talked to you about what is EVALI, how to diagnose it, and also how to follow it up. So for the next session, I will take you through a case and to highlight to you how should we manage a case of EVALI. So I have a case of a 23-year-old man who presents to you uh, with worsening fever and dyspnea. So this is a common thing that will come to your GP practice. So what are the history that you would like to ask this patient? Unfortunately, because we are short of time, I cannot open it up for all 200 plus of you to answer, but we will go through the case together. Okay, so of course, you will need a detail of the presenting symptoms. You need to have the presence of the other associated symptoms that you need to correlate with the presenting symptoms. And as we just passed the pandemic of COVID-19 and currently in an endemic time, so we should always actually explore the risk of COVID-19 and their vaccination. And you have to explore other comorbidities as well and all the other relevant risk factors. But not forgetting as well, we are in Malaysia. The rate of TB is still very high in Malaysia. So you have to ask history regarding tuberculosis and also the contact of tuberculosis. So as has been mentioned by Dr. Fazliana, okay, so the symptoms that is commonly presented in EVALI are the respiratory symptoms, the gastrointestinal symptoms, and constitutional symptoms. More than 70% of patients would actually present with respiratory symptoms, which are shortness of breath, cough, and also chest pain. But mind you, they can also present to you with GI symptoms, which are the nausea, vomiting, diarrhea, and abdominal pain. So please do not discount EVALI if they have exposure to vape or e-cigarette, if they only have gastrointestinal symptoms or constitutional symptoms. Okay, so in this patient, he presented with 3 days duration of symptoms. He had low-grade fever, which was relieved with paracetamol. There was a non-productive cough. He had pleuritic chest pain, but there was no gastrointestinal symptoms. He did not have any other comorbidities. Yeah, he had no traveling risk factor and was not living in dengue-prone area. He was an active smoker with history of vaping. He worked as a hawker and there was no TB or COVID-19 contact. So what further history would you like to ask on the smoking habit? Okay, so as has been mentioned by Dr. Liana much earlier, okay, you should ask the question on e-cigarette or vaping product use in these patients and what are their habits. Just to recap again, you need to ask them the e-cigarette use. When was the last time that they used it? How long did they use it? What was the method? It doesn't matter, as Dr. Liana has said. If they do not know whether they're dabbing meaning that you put the liquid on the cotton or they're dripping, yeah. So it's just that when they use it, even if it's aerosol, meaning that they're using it. Yeah, why? Because from the literature, it says that if the patient was dabbing or dripping the e-liquid straight either to the coil or to the cotton, then there will be higher dose of nicotine that they will be delivered. And you should ask also the frequency. When you ask the frequency, how often do they use it within a day, or are they only using e-cigarettes socially? And what are the other concomitant smoking product that is used, or whether they are using other substance as well. Yeah. And about the device and e-liquid, you need to know the product brand name, because when, say, there are a few people who will get EVALI based on this similar product, then they need to, the IK will need to go and check on this product, and they will go and search for this product. And what are the delivery system, as has been mentioned, whether it was a closed or open system, and if they know the substance used. Because as you remember, if it's an uh, open method, so they can put anything into the device. But if it's closed method, meaning that you just put straight the nicotine or whatever, and they can put cannabis, that they can put THC and other products into the device. Yeah, and you need to know the product sources. You need to ask for the product source as well. Okay, so for this patient, he smoked since the age of 15 years old. He smoked 1 pack a day, but he switched to vape just about 6 months ago. He last used the vape, yes, just the day before the presentation. He used it in aerosol. The frequency was 15 puffs per session, and he had 5 sessions to 10 sessions a day, and there was no concomitant other smoking product use or substance abuse. And the product name was XYZ. It was open delivery system, and the type of substance used was also unknown. It was bought online, as has been mentioned by Dr. Liana as well. You can easily get it online. So at this time, at this moment, what is your preliminary diagnosis based on the history? So again, he presented with respiratory symptoms. He had no other comorbidities or no other exposure. The only exposure that he had was to e-cigarette. Okay, so for differential diagnosis, you have to remember whatever is common is still common, as Dr. Afid has already mentioned. EVALI is a diagnosis of exclusion, and Dr. Fazlina has already mentioned what are the criteria that you need to look at before you diagnose EVALI. So you still have to remember to rule out upper respiratory tract infection, whether the patient has pneumonia or whether it's purely EVALI. Okay, so this patient, he was in mild respiratory distress, but he can still speak in full sentences, and he was pink. BP was stable. Pulse rate was tachycardic at 105 per minute. Respiratory rate was borderline tachypnea at 20 per minute, but his oxygen saturation was still okay at 95% under room air. The lungs was normal with equal vesicular blood sounds. So what are the investigation which you perform to confirm the diagnosis of EVALI? Okay, so if you have access to lab facility, you can send for the laboratory lab test. But if you do not, then you can straight away refer to either ED or the medical department, depending on the severity. Yeah, so for the lab investigation, you need to send, if you have the access, FBC, ESR, CRP, culture and sensitivity study for blood, sputum, and urine, urinalysis, and respiratory panel for influenza and other possible infectious pathogens. And if you can, autoimmune screening. Yeah, and in local setting, I have to stress again, you have to look for TB and also COVID-19. Okay, so for this patient, his hemoglobin was okay at 11. White cell was not very high at 11.1. Platelet was 304, neutrophil of 80%, and lymphocyte of 15%. His RP and LFT, renal function, and also liver function tests were normal. Yeah, the ABG was okay. Yeah, PO2 was still 63.1 millimeter mercury. ESR was just 30. CRP was 50. COVID-19 was negative. Sputum culture was negative. Okay, so this was the X-ray that was done. Okay, if you look at this, if you look at the X-ray, you can see that there are bilateral pulmonary infiltrates, and the cardiomegaly with a CT ratio of more than 0.5. Yeah, was slightly bigger than that. Yeah. So the imaging, as has been mentioned here, if you see the chest X-ray was abnormal, there was pulmonary infiltrate. So it is very crucial to have both exposure to e-cigarette and also abnormal imaging. Sometimes your X-ray can be normal. So if that happens, then you need to get a CT scan. But if you have an X-ray that is abnormal, that is sufficient for you to diagnose EVALI, provided that all the other investigations are negative. Yeah, for absolute diagnosis of EVALI. Yeah, so chest imaging is mandatory for the diagnosis of EVALI, and normal chest X-ray does not exclude the diagnosis of EVALI. Okay, so for this patient, all the investigation were negative. Yeah, respiratory viral panel, influenza PCR, AFB for the sputum, mycoplasma serology, the urine antigen, melioidosis, procalcitonin, hepatitis screening and HIV screening, yeah, urine FME, connective tissue screening, urine FME, echo was normal, 64, D-dimer was negative, and pro-NP was also normal. Okay, so summary for this case, a 23-year-old presented with acute respiratory symptoms associated with fever. He has history of vaping product exposure. His chest X-ray was normal. His other investigation was unremarkable. So what is your provisional diagnosis? Okay, so as has been mentioned before, if we look at the definition of confirmed EVALI, as I have mentioned a few times, you need to have the exposure to e-cigarette, and it has to be within 90 days. So this case fits that criteria. And he also had pulmonary infiltrate, which is the other mandatory criteria to diagnose EVALI. And if you look at this criteria again, you need to have the absence of pulmonary infection on initial workup. And the minimum criteria are the negative respiratory viral panel and negative influenza polymerase PCR or rapid test, if that is what is done locally. And you need to exclude all the other clinical indicated respiratory infectious diseases, and there is no evidence of medical record of alternative plausible diagnosis. So in this patient, based on this criteria, we can conclude that he had a confirmed EVALI. Okay, for probable EVALI, you will have the two criteria, which is exposure to e-cigarette within 90 days prior to symptom onset, and also pulmonary infiltrate. And if, say, you cannot do any of the tests, but you still think that it is highly likely that this is EVALI, or you say that this patient has other diagnosis that is still possible, but you still think that EVALI is highly likely, so it becomes a probable EVALI. Okay, something that I have to let you know and remind you here, this criteria is actually a surveillance criteria. This is not a diagnostic criteria. But at the moment, there is no other criteria that can be used to diagnose EVALI. And to diagnose EVALI, you do not need to do bronchoscopy or any other method, because there is no pathognomonic test or pathognomonic evidence to say once we have that evidence, then definitely it is EVALI. It is still based on the exposure and also the X-ray finding. Okay, so the differential diagnosis for EVALI is still whether the patient could still have infectious pneumonia, whether the patient has a diffuse parenchymal lung diseases or other diffuse lung diseases. Yeah, so basically you have to rule this out before you say that it is a confirmed EVALI. But if there are two different diseases that is there together, then it can still be a probable EVALI. Okay, and testing for or empirical treatment for the usual infectious pneumonia can be started if, say, you think that there is a likelihood that this patient also have pneumonia, then you can start the treatment. There is no there is no rule that say that you cannot start the treatment. Yeah. So as I've mentioned before, probability of alternative diagnosis increases when either the absence of typical demographic or clinical features of EVALI, yeah, presence of atypical presentation or presence of predisposing or for other illnesses. Now, say that if they come in with with stroke, or they come in with seizure, then you have to think of other things rather than EVALI, even though they actually have exposure to EVALI. Yeah, EVALI can be considered a leading or provisional diagnosis if none other illnesses is probable based on the above all this evaluation. Right? So in this case, it is a confirmed EVALI. So what would we do next? Okay, in local setting, yeah, if you are at the GP, if you have access to the chest X-ray, or if you go to the primary care center, if you have the history and abnormal chest X-ray, that is already sufficient for you to diagnose someone as a suspect of EVALI cases. And as mentioned by Dr. Afiq earlier, okay, you need to follow these patients up early. So if you have not a very severe case, a mild case, you can refer them to the medical department and get an appointment within 24 to 40 hours, because their rate of hospitalization and death is high among those with comorbidities. Yeah, but if the case is very severe, you will need to refer them to the emergency department. And in Malaysia, we have stated, because this disease is still new, so we make it a criteria that these cases need to be referred to the physician. Okay, so what are the indication for admission? This is just to let you know what are the indication for admission. Yeah, it is highly recommended for those with decreased oxygen saturation, less than 95%, but if the patient has a concurrent illness, especially if respiratory distress is present, comorbidities that compromise the pulmonary reserve, yeah, unreliable access to medical care, especially ability for follow-up within 24 to 48 hours and promptly in the event of rapid worsening respiratory symptoms, and if the patient have poor social support. Yeah, so in ED or PC, yeah, we need to determine the need for hospital admission, requiring the careful clinical judgment by the EP due to high risk of rehospitalization and mortality among EVALI patients. Yeah, and upon discharge from ED, say if EP thinks that they are well enough to be discharged, they can be prescribed for a short course of oral corticosteroid. If warranted, you can give them antiviral or antibiotic, education on warning signs, or follow-up in 24 to 48 hours. Okay. At the moment, still, as I have mentioned, the advice is to be seen by the physician. Yeah, at the moment, we do not actually advocate for all these patients to be only managed at a primary care level, because it is not a disease that is very familiar to everyone yet. Okay, so this I have mentioned. A physician should be consulted for any case suspected of e-cigarette or vaping product use associated lung injury for confirmation of diagnosis, and when seen at ED or primary care facility. Yeah. Okay, so that is the end of my talk. Thank you very much.